evening, everyone. Welcome to the rescheduled session 5 of the SCTS Foundation Doctor Academy. I'm very happy to be joined by Professor David Barron, who's a division head of cardiovascular surgery at the Hospital for Sick Children in Toronto. Came to Canada in June 2019 after being a consultant at Birmingham Children's Hospital since 1999. He's currently professor of surgery at the University of Toronto, and he's the director of the Adult Congenital Heart Surgery Program. Without further delay, over to you, Professor Barron.
Thanks, Hannah. You can hear me okay, yeah?
Perfect.
Yeah. Okay, well, welcome. I'm sorry it's been, we tried to share this a couple of other times, but it's not worked for one reason or another. I understand, you know, you're kind of foundation doctors, and you're kind of looking at a career potentially in cardiac surgery. So really, this is just a little taster of potentially, you know, the sorts of things that you'd encounter in cardiac surgery, looking at sort of, you know, at this subspecialty of congenital cardiac surgery, which is called congenital because, you know, obviously most of it is going to be in the surgery is going to be in children, but you know, we see adults who've got congenital heart disease as well, and so the specialty kind of encompasses both, and so your kind of your route into it is through absolute kind of standard cardiothoracic training programs, where you do adult cardiac and thoracic surgery. But if you think you're particularly interested in congenital, then most programs will give you an opportunity to see some congenital for at least kind of 6 months of your rotation. And then if you really think you want to do it as a career, then most people will tend to step sort of sideways and go into some sort of dedicated training in congenital for a couple of years, which can sort of overlap with your final sort of 6 year of training. This is kind of just a very sort of general talk, just to give you a feel of some of the things you might deal with. And the title I was sort of given was cyanotic heart disease, and we'll say what that is, but also perhaps, you know, try and focus on one lesion, which is Tetralogy of Fallot, which is one of the commonest types of cyanotic heart disease. Okay, in terms of, you know, congenital abnormalities, the heart is partly because the heart is so well studied, but the heart is probably one of the commonest organs to have congenital abnormalities within it. Often they're pretty minor, you know, the incidence, you know, is quite high. It's pretty consistent around the world, and with the time, you know, with the different eras, it stays pretty constant, and it's sort of said to be 8 per 1,000 live births, or I mean that's pretty close to one in 100 live births will have some sort of you know, identifiable congenital abnormality, even though some of those may be very minor. And when you start to try and think of, well, what could go wrong in the development of the heart, well, you know, really, you know, if you can think of it, it probably exists. So obviously holes in the heart are very common things that we talk about, and those holes obviously can be between any chambers within the heart. You know, any of the vessels connecting the heart can be narrowed or blocked. The valves themselves can be narrowed or leaking, or maybe very abnormally formed. Even valves can even be absent within the heart. And then you want to think about the chambers within the heart, and some of the chambers, the ventricles or the atria, can be underdeveloped or functioning abnormally, and you may get failed septation of both the arteries and of the chambers of the heart. So a good understanding of basic embryology is going to be really important for understanding congenital heart disease. But equally, you know, the veins or the arteries can be connected the wrong way round to the heart, and you can even get sort of mirror images of the heart rather than a left and a right side. So there are a whole myriad of different things that can happen, and they can happen in combination or in isolation. So there's a huge spectrum of disease to talk about. And quite a good way of classifying it is to sort of classify it between acyanotic and cyanotic heart disease. It's a good overall classification, and you know, it's something that's easy to understand in terms of its concept. Whether your patient has got heart disease but is fully oxygenated, got normal oxygen saturations, or whether they are desaturated and cyanosed. But I think a really key thing to remember when we talk about it is that to be cyanosed does not mean that you have not enough pulmonary blood flow. You might have low pulmonary blood flow, but it doesn't just to be blue. It isn't just because you haven't got enough blood going around the lungs. You really, to be truly cyanosed, you've got to have a shunt somewhere within your circulation. So there's got to be some way that the blue blood, you know, the venous blood is getting into your systemic circulation. So it's not really about low pulmonary blood flow. You can have high pulmonary blood flow and still be cyanosed. It's all about whether the blood is having to mix, whether you've got blue blood getting into the you know, to what should be the left side, the oxygenated side of the circulation. And you know, you can look at all sorts of categories of trying to classify what those are. But you know, so the typical sort of acyanotic you know, congenital heart diseases are where you've got a left to right shunt within the circulation. So blood's always going to go from high pressure to low pressure along a pressure gradient. And so, you know, a patent ductus, ASDs, VSDs, or what we call AVSDs, which are an atrioventricular septal defect. So there are more sort of complex type of defect right in the crux and the center of the heart, where you've got a defect both above and below the level of the inlet valves. But basically, you know, the physiology is again a big hole between the two sides of the heart. Blood will always go, you know, from high to low pressure, and so it's a left to right shunt, and so you're fully oxygenated because you've got plenty of oxygenated blood going around your body, and so these are acyanotic conditions. And similarly, you know, many of the obstructive lesions within the heart can equally be acyanotic, so you've got normal oxygen levels. So when we turn to look at today's topic, which is cyanotic conditions, somewhere there's got to be a right to left shunt within the circulation. So the blue blood in the right side of the circulation is somehow getting across to the left along the pressure gradient. And those are so what we'll talk about today, Tetralogy of Fallot and or pulmonary stenosis are the commonest. And that's a situation where you've got a big hole in the heart, a VSD. So the blood obviously can travel either way across the VSD, but it happens in combination with a narrowing of the pulmonary artery, or the muscle beneath the pulmonary artery. So there's kind of an obstruction to the blood getting through into the lungs. So the blood in the right ventricle will just take the easiest pathway out. And if the pulmonary valve or the region below the valve is small and narrow, then it's easier for the blood to go across the VSD from right to left and out through the aorta. So that's where you're getting the shunt occurring, and where you get the mixing of the blue and the red blood. So the blue blood ends up going back around the circulation, and then your oxygen levels are reduced as a consequence. And other sort of conditions, there are a whole list of them, where you may have you know, obligate mixing of the blue and the red blood. So it could be conditions where only really one side of the heart forms properly. So typically sort of tricuspid atresia. So if you imagine that your tricuspid valve never forms, usually that means the whole right ventricle never forms properly. So all the blue blood that's coming back to the right atrium in your vena cava has got to get out somehow. It's got to get out of the right atrium somewhere, and there's no tricuspid valve. So it goes across the atrial septum, across the atrial communication, so a PFO or an ASD, and gets into the circulation that way. So that's blue blood getting across the ASD into the left atrium. And so you've got mixing of blood, so your blood's going to be desaturated, and so you're going to be cyanosed. So that's a whole family of conditions where you may only have one properly developed ventricle, where you're going to have obligate mixing of blue and red blood, and that's going to mean you're going to be cyanosed. And the other sorts of conditions that could cause cyanosis, very importantly, is transposition of the great arteries. So that is where the aorta and the pulmonary artery are connected the wrong way round. So your blue blood comes back into the right atrium, into the right ventricle, and then goes back out of the aorta because you're connected up the wrong way. And likewise, the red blood comes back to the left atrium, goes into the left ventricle, and is then pumped back into the lungs again. And so you don't get the oxygenated blood going around the systemic circulation where you want it to. So you can be very, very cyanosed in that condition. Your lungs are perfectly healthy, and there's plenty of blood flow going around the lungs, but the problem is none of it can get into the systemic circulation. So that's a different reason for being cyanosed. And you can only survive because usually there's some sort of connection between the two sides of the circulation, either at the level of the atrial septum or with a ductus, that's patent ductus arteriosus, that stays open, and that at least allows some of that oxygenated blood that's in the right, in the right side of the circulation to get into the systemic circulation. One other thing you can happen is you can have completely anomalous pulmonary venous connections. So normally your pulmonary veins should join into the back of the left atrium to bring all your oxygenated blood into the left side of the heart. But there are conditions called total anomalous pulmonary venous connection, TAPVC, where all the pulmonary veins come together to a little confluence, but instead of draining into the left atrium, they drain into the right atrium or into one of the vena cava. So then again, you've got all the red blood has to go into the right side of the circulation before it can get its way back around the systemic circulation. So again, you've then got obligate mixing of the blue and the red blood before it makes its way across the atrial septum to get around the circulation. So again, there's another way that you can be cyanosed because you've got obligate mixing of the two sides of the circulation. So that's just a kind of feel for the fact that you can have all sorts of reasons why you may be cyanosed, and they all will have some sort of surgical solution to either correct your anatomy completely or to give you a circulation which at least is safe with some mixing. So let's talk about Tetralogy of Fallot. Just it's a good example of cyanotic heart disease, and also gives you a feel for what sort of you might be faced with in terms of a career in congenital cardiac surgery. It's named for Etienne Fallot, who's a French morphologist and anatomist in way back in the 19th century, who was the first to really kind of describe the condition, calling it la maladie bleue, because the patients that they saw were these usually children, because if you had severe Tetralogy of Fallot before there any kind of surgery or intervention was available, then it was a lethal disease in babies. But those that were slightly better balanced could live, although they were blue, they were cyanosed, and these were the sort of cyanosed children, the commonest reason for having a sort of cyanosed child. And that the reason is you can understand why it's a kind of balanced lesion. If you just have a very big VSD with a normal pulmonary artery, then the blood will just flow and blast its way into the lungs because nothing's stopping it. The resistance in the lungs are like a sponge with very low resistance in them. So all the blood just flows without any hold up into the lungs. So your lungs are flooded if you've just got a VSD and you go into high output cardiac failure with congested lungs. But of course, you're not blue because it's all red blood going round and round the circulation. So if you just have a big VSD and then it's usually a pretty lethal condition within a few months, because the babies usually will struggle into heart failure and can't cope. So if you have pulmonary stenosis as well as a big VSD, then you're actually protected a bit from that high risk problem of being over circulating your lungs, because the small pulmonary artery and pulmonary stenosis, often at multiple levels, will protect your lungs from being over circulated, and so you don't die of heart failure. But of course, depending on how severe the narrowing is, you may not get enough blood through that small pulmonary artery, and therefore you get right to left shunting across the VSD, so you're blue. But you can survive because you've got good cardiac output. You've got plenty of preload on the left side of the heart, so you've got good flow around the body. You just haven't got enough, the blood's not all going to the right places, so you can be blue. So children and right up into adolescence, if they were lucky, and young adults could survive with uncorrected tetralogy of Fallot if they had a good balance. So it was a kind of survivable condition in that way. But of course, back then, there was obviously no treatment for it. So tetralogy is sort of the commonest type of cyanotic heart disease. So if you looked at the whole kind of spectrum of congenital heart disease, it's a decent amount of it. It's 7 to 8% of everything that we see in terms of tetralogy and all of its kind of variants. So it's the commonest condition, and it's got, of course, it's a tetralogy. So as described, it has 4 main components. So it's got typically sort of large subaortic VSD, so a big defect in the ventricular septum immediately beneath the aortic valve, and such. I'll show you some pictures. So the aorta kind of overrides, straddles that big VSD immediately beneath it. And in combination, you get a multi-level obstruction to the right outflow tract, to the way out of the right ventricle. So it can be both muscular in the muscle leading out of it. It can be at the valve itself. So the valve itself can be small and thick and abnormal. And the actual annulus of the pulmonary valve is also small and abnormal. The consequence of that is inevitably you'll get right ventricular hypertrophy, because the right ventricle's got to work much harder than usual. There's a huge VSD, so it's going to be at high pressure. The pressure in the left ventricle is going to be the same as the pressure in the right ventricle. So it's working at much higher pressure than in a normal heart. And also, it can't squeeze the blood through the narrowed pulmonary artery. So it's also got to work against an obstruction. So you get this combination of things all happening together. And you can actually put it all together with a single morphological description, which is actually anterocephalad, meaning anterior and headwards deviation of the outflow septum of the heart. And that's really that's the morphological lesion that characterizes tetralogy of Fallot, because it's that deviation of the outlet septum which leaves a defect behind it, which is the VSD, but also creates a small right outflow tract. And so that single sort of morphological characteristic really is what leads to the whole abnormality. And of course, it happens in a spectrum. Almost everything we see, in morphology, whether it's in the heart or any other organ of the body, you'll see a spectrum of it. And so you see more severe versions and less severe degrees of outflow tract obstruction. So is everybody okay? You're following okay? I'm just sort of carrying on blind, but please shout out or unmute yourselves if you want to ask anything. Nabil, hi. You put your thumb up. Okay, I'll carry on. So here's some just simple diagrams that perhaps sort of show you some of the features of tetralogy. So here's a normal heart on the left-hand side, where you can see the tricuspid valve leading into the right ventricle, leading out to a nice big normal pulmonary artery here and pulmonary valve. So the area beneath the pulmonary artery is called the infundibulum. It's like a muscular tube or sleeve that leads out of the right ventricle, and you can see that looks wide open and there's no obstruction anywhere. if you have tetralogy of Fallot, you've got this red thing here is the big VSD, a big defect in the ventricular septum. So on the other side of that hole is the left ventricle. And the outflow septum component here, which I'm just showing you there, that's the sort of the outflow component of the septum, which is moved anteriorly and superiorly. And so not only does it leave a hole behind it, but it creates a small, narrow muscular infundibulum to the right ventricle. And because it's all small, the valve doesn't develop properly, and the main pulmonary artery is small as well. Yes, there's the VSD. So, as I've said, so spectrum of morphology, much as you would see, you know, in everything that we encounter really in congenital heart disease, it's the same. I'm sure, you know, you'll see various degrees in acquired, you know, heart disease as well. But you know, it can be variability. So in that some of it is like a muscular overgrowth and hypertrophy, on top of the kind of fixed anatomical defects, you're going to have maybe a dynamic component to it as well, because the muscle is going to be contracting and relaxing during the cardiac cycle, so it can actually worsen or lessen the degree of obstruction in the muscular infundibulum in these patients. And that's really the cause of what was called spelling in these children, where they'd have episodes where they'd get much bluer because usually of some over contraction of the muscle in the right ventricle that was further limiting the forward flow through the pulmonary arteries. So the degree is, you know, is variable, and this is really what I was just explaining to you. It's certainly, you know, certainly a quarter of all you know, children born with tetralogy wouldn't be able to survive beyond the first year, and only you know, a third would survive beyond 10 years of age, you know, before there was intervention for this condition. So, you know, it's a very, you know, serious condition in terms of your sort of your survival, and even those that would survive would be surviving at the expense of being limited by their degree of cyanosis, which is variable, you know, depending on how severe the outflow tract obstruction is. But it tends to get progressive, because as years go by, the degree of hypertrophy within the muscle will progress, creating increasing degree of stenosis and blockage to the forward flow through to the lungs. But if you're really lucky and you've got some but not too much blockage leading out to the lungs, you may be relatively well balanced and actually maintain relatively good oxygen saturations if you're really lucky. So that's just a reminder that not everybody needs immediate sort of intervention with tetralogy of Fallot. And one of the most important things to then think about is, if you're thinking about how you're going to fix this surgically, you know, certainly back in the early days of heart surgery, when you really, you know, people were reluctant to operate on neonates or small infants, and all the risks of bypass surgery in a small infant, then there were many, people would favor some form of a kind of staged approach where you could relieve the cyanosis a little bit for a period of time until the child was bigger and stronger, and then do the repair later on. So these were kind of called staged approaches to managing the condition, and tend to still hang on to the rather old-fashioned term of calling them a sort of palliative procedure. Palliative meaning you're not curing the condition, you're only kind of improving it. And so a staged operation where you might do some sort of initial surgery first and then come back and repair it means a kind of staged approach. And there's still a debate today even over whether we should still use a staged approach in some patients, which hopefully we can talk about a bit later if we've got time. But I don't like the use of palliative, because palliation now really is a term that's used, you know, in sort of end of life care, and perhaps, you know, in cancer care where you're unable to cure the condition. And I think it's not so helpful to use it in the setting of something like cardiac surgery, where it's a deliberate, planned, sort of staged procedure with a plan for complete correction in the future. So this is the surgery. Okay? So if you put your mind to the condition itself, then, well, how can we fix it? How can we try and return a heart like this back to a normal circulation? And there are essentially two main components. Obviously, you've got to close the hole in the heart. You've got to close the VSD. And we do that by literally sewing a little patch inside the heart to seal off that hole. And the second thing we're going to need to do is open up all this narrowed and sort of partially blocked outflow tract to the right ventricle, so that when the right ventricle contracts, it can send all the blood around the lungs without any obstruction that it has to work against. Because if you don't relieve the obstruction, then the right ventricle will fail, because it can't offload through the VSD like it has been doing. It needs to be able to pump the blood into the lungs without any holdup. So the repair, if you look at this sort of diagram on the right, is to close off the VSD with a patch. So you've now sealed off, separated or septated one ventricle from the other. And then we've opened up all this narrowed area, usually by cutting away some muscle beneath the valve and opening up the main pulmonary artery and the valve itself with a patch to open it up to a normal size. And that hopefully should physiologically give you a normal circulation. So now you've separated the circulations. There's nothing stopping the blood getting through to the lungs. So now all the blue blood will go where you need it to, and you've got a corrected normal circulation. You know, the ventricles are now exposed to a normal volume load, and the same cardiac output is going through the left side of the heart as is going through the right side of the heart. Here's a sort of how could you do it? How could you actually affect that sort of repair? And in the earlier days of cardiac surgery, the surgery was done through the right ventricle. So actually cut through the right ventricle and close the VSD, working through the free wall of the right ventricle, and then place the patch to patch open the whole outflow tract and relieve the stenosis that way. These days, and really for the last 20-25 years or so, most of the repairs can now be done working through the atrium. So we try and avoid making big incisions into the muscularized right ventricle, and try and spare that to try and minimize the injury to the heart. And actually you can work through the right atrium, looking through the tricuspid valve, and you can repair the VSD and resect muscle working actually through the tricuspid valve itself. So you haven't got to reopen the ventricle at all, except for maybe a very short distance just to open up the infundibulum where it's too narrowed, to place a patch over the outflow tract. Usually a patch that crosses for a very short distance, but actually crosses the annulus of the pulmonary valve. And to give you a feel of how cardiac surgery has changed over the decades. The very earliest repairs were done in the 1960s, the very early days of cardiopulmonary bypass. And really, in those days, it was congenital heart disease that was really the driving force for all the technology that drove the heart-lung machine and the ability to be able to operate on the heart, because those were the lesions that people were most conscious of, and that people could see that if you had a way of managing the circulation, you could actually correct some of these cardiac lesions. So it was way back in the 60s, and you can see, as you might expect, in those very early days, the outcomes, it was a very high risk procedure, and the outcomes were poor. So the outcomes, as you look at as the decades go by, have changed dramatically. And right up to the sort of 2000s, and since, really the operative mortality, the risk with a tetralogy repair, which is usually done in infancy, is close to zero. So it's certainly no more than 1% or a half of 1%. So it's remarkably successful corrective surgery now. And so that really reflects the progress that's been made in cardiopulmonary bypass and in cardiac surgical techniques, just in the last 50 or 60 years. But interestingly, the cost, of course, of getting better at what we do is you then start to become aware of the sequelae of the surgery that you're doing, and the fact that some of these patients may need re-interventions. And so the actual number of re-interventions being needed on these patients is going up, because we're starting to appreciate that our job is not finished when you repair the condition as a young child, and that we've really got to try and make sure that these hearts remain as healthy as possible for a long life. And the life expectancy now of somebody born with Tetralogy of Fallot, the median life expectancy is into their 70s, but it's still not quite the same as the normal population, and that's because they do still run into trouble with problems with their right ventricle. And so we want to now learn from that experience and try and optimize the right ventricular function, which may mean further surgery as these patients grow up, and we'll talk about that in a minute. But these are some of the sort of players who've really made a difference, and it was in the sort of late 80s, early 90s that it became clear that you didn't have to wait for years and years to do the tetralogy repair, because even up until the sort of 1980s, all these tetralogy patients were usually being delayed or palliated, as we talked about before, prior to repair, because people didn't feel comfortable or safe doing repair until patients were sort of 3, 4, 5, 6 years of age, and so lived a sort of life as a cyanosed child until that time. And it became, this was Aldo Castaneda in Boston in the US, and Brian Barrett Boys in New Zealand, who really pioneered and showed that you could actually repair Tetralogy of Fallot in infancy, and you didn't need to delay for so long. And so things started to change, and the fact that earlier you repaired these patients, you were going to get less long-term damage to the right ventricle, because there was less time to develop hypertrophy or fibrosis within the right ventricle, and you get better flow through the pulmonary arteries at an earlier age, so you therefore get better development of the pulmonary arteries and better pulmonary vasculature. And so really now, as I just mentioned to you, that's from Toronto. Really survival has transformed really over that time, and these we're looking at children who were operated in the 90s, and now I say outcomes are even better. And these were some outcomes from the UK data. I'm sure you may have seen some of these curves on the what's called the CCAD website for the national reporting of congenital cardiac outcomes, and shows you the outcomes that you can see. Every little marker is one of the cardiac centres across the UK. You can see that the thick grey line is the median survival. So across all the centres in the UK now, you can see that really you're getting very good outcomes, 99% survival at a year. So really it can be done reproducibly and effectively, really across all the kind of cardiac centres nowadays. So it's a very successful procedure. And here just a quick sort of picture of these. So it's typically done in an infant. We'll usually electively plan to repair Tetralogy of Fallot between 3 and 6 months of age. And you can see here just a little view. You've got these little retractors in the tricuspid valve orifice, and we're looking through the tricuspid valve, and these pair of forceps are actually through the VSD itself. So obviously you're talking about a sort of 4 or 5 kilo baby, so the whole space you're working in is quite small. But this is the VSD, and this is the channel leading out towards the right outflow tract, which is small, where you can see already some of the muscle is being divided. And here a bit later on, you can see where the patch has been placed into the VSD, and some of these big muscle bundles have been divided that are leading out of the right ventricle, which is part of the process of enlarging that right outflow tract. So then here's if I can orientate yourselves, but you're looking here at the heart in the operating theatre with you can see the little bypass cannula and so forth in sight. What we're looking at here, this is the right outflow tract that's been opened up through the valve, because the valve is small, and you can see here the muscle of the infundibulum beneath the valve, which has been opened up, and then a little patch, usually of pericardium, placed over the outflow tract to enlarge it once you've cut through the narrowest area, cut away the muscle beneath it. You've cut away more muscle working through from the right atrium, and you're left with this little patch that crosses the annulus, and so it's called a transannular patch on the outflow tract. So the majority of cases will need some sort of patch across the outflow tract. So those that are really lucky have got a decent sized pulmonary valve and their obstruction is mostly muscular beneath the valve. You may well be able to just cut away the muscle in those cases and not have to disrupt the valve at all. That's the essentials of the surgery. And then, of course, your job as a cardiac surgeon is only part done when you've completed the surgery. So you'd always do an echo scan, usually transesophageal echo, in the operating theatre to look at your result, be happy you've really got a good quality repair. You don't want to leave the operating theatre without good quality repair. But then also, as a cardiac surgeon, you work very closely with the intensive care and with your cardiology colleagues to look after these patients post-op. Because if you think about what you've just done to the right ventricle, yes, you've corrected the circulation, and then hopefully now you've got all the blood flowing freely into the pulmonary arteries. But to achieve that, you've had to obviously have a period of cardiopulmonary bypass, which may cause a bit of myocardial edema and a little bit of impaired ventricular function. You've actually had to cut into the ventricular muscle itself, which is also obviously going to make the ventricle a little bit unhappy and not be able to contract as comfortably or normally as possible. And you've probably, in most of these patients where you have had to cross the annulus and provide them with a transannular patch, you've given them some tricuspid regurgitation, some pulmonary regurgitation. So you can't help that. It's the only way you can make a big enough outflow tract in an infant. So you've got a ventricle that's a little bit sorry for itself. It's had a lot of work done on it, muscle cut out of it, and you've given it pulmonary regurgitation. So the result can be a slightly stiff and slightly unhappy right ventricle, just in the early post-operative phase. So what we see is what we call a restrictive sort of right ventricle. It's rather stiff. It can't necessarily react to wanting to increase or decrease its stroke volume. And it's also having to cope with pulmonary regurgitation that it hasn't had to cope with before. And so what you often see is a rather stiff right ventricle. And here's an echo tracing where you can see the forward flow through the pulmonary artery. But you also see that when the atrium contracts, you see the atrial contraction almost transmitted as a little extra, little sort of extra wave on the Doppler flow recording during atrial contraction, so in diastole. And when you see that, it's quite typical of a kind of what we call a rather stiff or restrictive right ventricle in the immediate post-op period. And so there's also a risk of causing heart block because the conduction tissue is very close to the VSD margin. So you may get temporary or even prolonged heart block following the surgery, which may also impair the efficiency or the contractility of the heart. And you can also get tachycardias and fast heart rates, all of which are going to need managing at the bedside in the post-operative period. And it needs a thoughtful and combined management from both the surgeon and the intensivist working together. And one solution that some people like is leave the child with a small ASD deliberately at the end of the surgery. And that means if the right side of the heart is feeling rather sorry for itself and struggling a little bit and a bit restrictive and stiff, then you can allow some of the blood in the right atrium to go across an ASD. So that's a right to left shunt, right? So that will mean cyanosis. So that you may drop the oxygen levels a little bit, but the benefit is you're providing plenty of preload on the left ventricle. So you maintain good cardiac output, even if the right ventricle is feeling rather sorry for itself. And once you get out of that very early post-operative phase, right ventricular function will improve, the stiffness goes away, and the heart becomes much happier, and then the pressures will drop away in the right atrium, and any shunting across the ASD will become left to right, and so it will just resolve itself. So really important, you think about the physiology, think about the post-op physiology, and that you work together with intensive care and cardiology to manage the condition. Now, I can see time is flying by, so I think let me really just fly through. We haven't got, we could talk through some of the original sort of palliative things that were done for Tetralogy of Fallot, like the original sort of shunt operations that were done. But I think we're going to run out of time. It's better you have a bit of time that you can ask me questions and talk about things. So why don't we just sort of find a place to stop, and you can ask me some questions. Where are we?
Thank you very much.
Go ahead.
For a very interesting and comprehensive talk, Prof. Barron, and thanks a lot for taking the time. Well, I'll take some questions and I'll start off if that's okay. You answered the first question I had about the VSD and the conduction issues. When you widen the right ventricular outflow tract and you improve flow into the pulmonary circulation, do these patients develop pulmonary edema, or does that not really happen?
No, in theory, you could get a kind of reperfusion injury to the lungs, but usually the pulmonary vasculature is perfectly normally formed in Tetralogy of Fallot. It's just you've got this proximal sort of hold up to blood flow. So it is true that you'll probably increase the flow into the lungs after the tetralogy repair, but of course the pressure is low because the heart is septated. The resistance within the lungs is very low. So you always think of the lungs like a sponge. The blood just floods into it so easily because the resistance is so low. So although you're increasing the flow, it doesn't usually cause any reperfusion injury of note. So you don't really get pulmonary edema. You may very rarely get some reperfusion edema, but it's not usual. You tolerate it very well. The lungs just say thank you very much.
In the earlier post-operative period, when the right ventricle isn't necessarily functioning as well, do patients get any liver congestion or liver failure as a result of that?
Well, they can do. No, exactly right. So you can get a high right atrial pressure, so you do get some liver congestion, but I say you can effectively be in low cardiac output if you've really got the right side is really struggling in those early few hours or few days, and hence why an ASD could be helpful to offload the right ventricle, because usually it's just a temporary thing. But yes, you can do, and one of the consequences of high venous pressure on the right side of the heart is that you then can start to develop third space fluid collections, because your lymph system then can't work effectively because your lymph can't get back into the venous circulation so easily because the pressure's high in the venous circulation. So you get pleural effusions, you get ascites, and you've got to watch out for all those things as well. So you can very easily see that the concept of the surgery sounds really straightforward, but it's unforgiving. So congenital heart surgery, I think, just as many forms of cardiac surgery are, it's very unforgiving. So if you don't get your repair perfect, maybe you leave a residual VSD, or maybe the tricuspid valve is a bit snaffled in or trapped by your VSD closure, and so the tricuspid valve becomes regurgitant, then suddenly you've got a perfect storm of problems. You've got a right ventricle that's already unhappy, you've got a residual VSD, so you've got extra volume load on the right ventricle, and you've got tricuspid regurgitation on top of it. So very quickly you end up with a whole mass of problems that you're going to have to handle in the ICU. Hence the importance of really attention to detail, getting things right in the operating theatre, and getting a good echo to try and make sure everything's good before you leave the operating room.
Thank you very much for that. It sounds like there's lots of applied physiology at the time of the actual surgery, which sounds really interesting.
Yeah, I think what's one of the really attractive things about congenital as a sort of subspecialty is the physiology is really interesting, and you've really got to think about the physiology and how you manage these circulations, particularly how we manage circulations that are essentially working with a single ventricle, so what we call the functionally univentricular circulations, where you can find a way through for these children to have a very good quality of life, even with a single ventricle. But you've really got to think your way through the physiology to get there.
Okay, thank you. Are there any other questions? Go for it, Nabil.
Hi, everyone. Nabil here. I'm one of the cardiothoracic trainees here. Thanks, Prof. Barron, for a great talk. First, I want to mention that it's great to see foundation doctors interested in congenital heart surgery. I think it's a great specialty and you should go ahead with it. Prof. Barron, two questions. One, during your career, how's the role of using the BT shunt changed, particularly in stage procedures? And the second part to that question is the role of the RVOT stent by our cardiology colleagues. In what circumstances do you think the role of the RVOT stent is good? And your experience with having to take them out later on down the line when you do a definitive repair?
Yeah, so Nabil's asking some very important questions. So these are things we didn't have a chance to talk about. I'm sure you've all, well, I hope you've all heard of the BT shunt, which is the Blalock-Taussig shunt, where I'm trying to find the right slides to help you. But it was a very simple but very effective way of palliating, here we are, the circulation. So the idea was really that you took, I'm trying to look for a better picture. Really, the original idea was you took these were the blue children who just didn't have enough pulmonary blood flow with severe Tetralogy of Fallot. So the idea was, how could you get more blood flow into the lungs? And the answer was take the subclavian artery, turn it down, and actually plumb the subclavian artery into the pulmonary artery to drive extra blood flow into the lungs. So, done through a thoracotomy before the age of bypass. Yeah, it was done in the 1950s. And you could transform these children who were blue and cyanosed into a far less degree of cyanosis. It still doesn't cure their cyanosis because you've still got obligate mixing of the blood within the circulation. But just because you're putting so much more blood flow through the lungs, it reduced the cyanosis. So the BT shunt was very clever at the time, but it's and nowadays we do it with a I'm trying to say, I've got a picture of it. Nowadays we do it with a little Gore-Tex interposition shunt here, like here on the right. So taken off we still do it. So it's usually done in neonates who are very cyanosed, and you don't want to do a complete repair, but you place the shunt between the subclavian artery or the innominate artery onto the right pulmonary artery. So it just drives blood in under pressure to give you more pulmonary blood flow, which can be life-saving. But of course, it does so at the expense of a volume load on the circulation, because this is extra blood. The left heart's got to pump into the lungs, and you get a diastolic runoff of blood into the lungs. So again, important to think about your physiology. So it's kind of been used less and less over the years. Still an important operation to have in our armamentarium, but it means that in diastole, so again, think of your physiology, pressure in systole is higher in the subclavian artery than it is in the pulmonary artery. So blood goes north-south in that picture. In diastole, it's the same, yeah, because in diastole, your pressure is high in the systemic circulation to the pulmonary. So you've got systolic and diastolic flow constantly into the lungs during this cardiac cycle. And that can mean that in diastole, your blood pressure really drops away as the blood rushes down the shunt in diastole, and that can lead to poor coronary perfusion, and it can impair your heart function, particularly in a neonate. So over the years we've used shunts less and less, and we're looking at other ways of providing pulmonary blood flow that aren't so invasive. One is just to stent the ductus, if the ductus is still there, as it might be in a newborn, and stent the duct open in the cath lab. Or probably more effective is an RVOT stent. Yeah. So this is where the cardiologists actually place a little coronary stent across the right outflow tract to stretch open that narrow long infundibulum and open up the valve if the valve is small. And that is a physiologically, again, think of the physiology, is much more efficient, because in systole you'll get forward flow from the right ventricle through into the pulmonary arteries, but in diastole there'll be much less flow. So because the pressure in the empty right ventricle is going to be similar to the pressure in the pulmonary arteries. So you don't get so much diastolic runoff into the lungs, and so the blood pressure is much better sustained. So it's much safer from that point of view. But also the blood going through the RVOT stent is mostly going to be blue blood, because it's come into the right ventricle from the right atrium. So most of it is blue blood. So all the blood that's going into the lungs is desaturated blood that's hungry for oxygen. So you'll get lots of oxygen pickup from the blood that's going into the lungs. Whereas if you do a BT shunt, then the blood is already partially oxygenated when it goes into the lungs. So it's not so hungry for oxygen. So you don't, for the same amount of blood going through the lungs, you get less oxygenation benefit. So the RVOT stent is far more attractive to me as a way of palliating, if you like, or staging the repair of patients who you think are too small or too fragile to go through repair. So I think this is really important for management of the really sick cyanosed neonate who needs intervention. And yes, it means that when you come to do the repair, you've got to carve the stent out of the heart. It's not usually a big deal. I don't think, Nabil, to your question. It does add maybe 5 minutes to the surgery, and it probably commits you to a transannular patch. But the truth is, all of these neonates who are really sick and have a small outflow tract would have needed a transannular patch anyway. So I think for the sake of a slightly more complicated surgery, I'd rather do that than try and embark on a complete repair in a 2.5 kilo neonate who's really sick and really blue.
Thank you.
Question there from Mostyn.
Yes, hello, thank you. Medical student, so apologies if I don't know very much. I was just wondering, when you were saying that most children are operated on at 3 to 6 months, I presume, is that because they're too unstable, too small to be operated on before? And I was wondering if you've seen this age decrease over time with sort of developments in bypass and other technologies.
Yeah, the overall age has come down over the decades, but most babies with Tetralogy of Fallot aren't desperately blue. So there's no real press to need to operate on them as newborns. And the newborn physiology can be quite difficult to manage. Some of your organ systems are still relatively immature, particularly your brain, and you want to avoid exposing those organ systems to bypass if you can, if there's no real need or benefit. And so what we've found really is that probably 3 to 6 months of age is the best sort of sweet spot for getting early repair without needing to necessarily repair the neonates. We do sometimes repair them as a neonate, but it's not always necessary. So what we're looking for strategies all the time to minimize your risks and maximize the benefit. So it seems that repairing them at sort of 3 to 6 months of age, certainly at the moment, is the right thing to do and gives you the best outcomes with minimal sort of post-operative complications and really good sort of long-term outcomes.
Thank you. And if I may, just one more question about the ASD that you said some people leave behind.
Yeah.
I was wondering, would you ever consider repairing that later on, or is it just kept open forever, and whether that increases risks of things like strokes in the future? Yeah,
it may potentially, it's going to be small, so it's not going to provide a big worry about a sort of volume load on the circulation. But if you're worried about it, as you say, there is a theoretical, a very small risk of stroke if people have an ASD. Then you could always close it. You could close it in the cath lab with a little device, because that's all it would need, because it's just a little hole we leave behind right in the center of the septum. So it'd be easy to close it with a device in the cath lab. So if you did want to close it, you could do it without surgery. You could do it with a catheter device.